there were also passed schools and no celebration and she has celebration of incomplete evacuation after education and textbooks also present and there's no many symptoms and regarding the alteration of our habits, increase the frequency of passing tools initially first once a day and then it goes up to 6 to 7 times a day and she passed schools as well, no serious diarrhea and she's there's no feature scientific work which have been like joint pain and she's not having any symptoms and there's no consumption of excessive oily and no smoking and there's no significant loss of weight or loss of appetite during 6 months, past 6 months and she occasionally consumes wine and there's no early morning headache, no back pain, no inflammation of eye, no recurrent UTI, no significant past medical history. She underwent 2 road-saving infection and no significant allergic history. Regarding family history, there's no family history of colorectal cancer, so it can impact pregnancy. In social history, she is married, she is a mother of 2 children, she is a housewife, husband is a police officer, she is having good family support by the mother, and this condition affect her activities of daily living. On examination, she is non-pagetic, she is well-looking, and she is integral, no hollow, and no red eye. She is not listening, and there's no superciliary lymph node, no rubbing, no trauma edema, no fatty tremors, no ankle edema, heart rate was 64 beats per minute. On abdominal examination, abdominal is not distended, penetration scar is present, and abdominal no speech respiration, no dilated veins. No speech respiration, no dilated veins. On palpation, abdominal is soft, non-tender, no palpable masses, and no bulbar kidneys, no flat dullness, and bowels also present. On auscultation, the lungs were clear. On DRE, blind DRE findings.
When you say auscultation, lungs were clear?
No, basic. Regarding findings, no fiber or visible lungs, and the respiratory wall is normal, and on examination of lung, there is inspection of lung. Inspection of the lung.
Blood. You couldn't say that, yeah?
There are skills and there is red change on the lung.
It's a proper term. You don't say this is a device to write things on a paper, write a page. Isn't it? Right. Use proper terms. Is that a road map? Is that a road map? Yeah. That was contextual. Some
46 years old female, ASA1, presented with colorectal bleeding and alteration of bowel habits for 6 months duration, dark cast missing stools as well as stools were present on stools, and there was
No significant.
for the first findings. GI examination, blood change, and blood.
She's a 62-year-old female. 46. 46-year-old female with her rectal bleeding for a period of 6 months. The bleeding was mixed with stool, the blood was mixed with stool, and as well as a bit of streak appearance. And what are the important negatives? There is no significant mucus discharge, tenesmus, incomplete evacuation. She had a you say rectal bleeding associated with tenesmus. Is there incomplete evacuation also? Tenesmus and incomplete evacuation. No mucus? No mucus. There is mucus. There is mucus. Okay, so all these are positive. There is no, but no spurious. Right? So if you have mucus, the chances of getting spurious is higher. Specifically inspired. But how do you ask spurious? Later, keep a bar of Palabaka bathroom and no. That is what is known as spurious. Because they want to go to the bathroom several times. Because there is mucus people. Overnight, there was mucus produced by the tube. Usually these animal hospitals. They produce a lot of mucus. So this mucus that was produced during the night, they wake up, they want to go to the bathroom because this feels incorrect. So they go once and then it's not enough, they probably go again after a little while. So they go about 3 or 4 times in the morning. So you don't ask for that. Ask, it's okay to ask for this. Ask for this. So you want to so they want to next week, you want to bathroom in that no. If there is a spurious area, it's positive. You should have that or not. At one point, you said you open probably about 6 to 7 times a day. So all that is after the morning. So that itself is kind of spurious, isn't it? So don't say spurious there is not there when you say bowel opening is about 6 to 7 times a day. That goes on to show that you haven't understood the principle behind what is spurious there. It doesn't necessarily need to be early in the morning. You have to go to the bathroom 6 or 7 times a day and you are not passing enough. You are not passing feces, but you are passing enough mucus and it's considered as spurious. Right? Diarrhea is basically open bowel several times a day. Spurious means it's actually false, it's not really bowel open. So, you say both together and say there is no spurious, then you don't understand what is happening in the terms. Right. And then there is no significant history of polycyclic abdominal pain. Did you mention that? That's a very important finding in your history that you have to ask the patient. Why is it important? There is a patient is going into obstruction, central obstruction time to time. Where the thing would be if the patient has this generally. Forget about small bowel, we are talking about a colorectal rectal sigmoid. We have it using the rectal sigmoid, you tend to have this kind of picture where you get on and off abdominal pain. Not because of, it's not polycy per se, small bowel polycy, you know that. Large bowel is there, small peristalsis does not happen in large bowel. It is segmentation and AMCs. What are those AMCs? I can't remember what AMC stands for. Some reflection, I don't know. MMCs, not AMCs, MMCs. So that's the reason why you get that kind of a polycyclic pain. It's not important, but you get that. So that's a very important thing to ask in the history. going back to summary, I'm just going through your history, right? So first, the principal thing you do in parental thinking history is you describe what the parental thinking is, right? So don't try to describe fecal metacal dysfunction and all that. Just give an overall picture whether this parental thinking is switched to or whether this is bleeding after defecation as droplets or whether there is streak-like appearance of blood on feces. Right? And then the site, whether the feces, the site, whether the patient is passing normal size feces or whether like pencil-like feces or not, the chances are that there is a narrowing, it's a circumferential narrowing. That's why you are passing that kind of. So you ask the patient, if the patient has that, you tell that. If the patient doesn't have that, you don't tell. The patient is not passing this here. If the patient has that, you tell that. Right? And then, of course, whether there is associated tenesmus, incomplete evacuations, furious diarrhea, production of mucus, all those features of a rectal malignancy you have to mention they are there or not. It's a must. Then about the abdominal pain. Generally, that is the flow of a history of the rectal pain. Then, once you have said these things, I would probably consider talking about what is your body, principal body, then it's the malignancy. Right? Of course, you have to consider the other possibilities like inflammatory problems. It's true. So mentioning a few things pertaining to that is good. So if the patient has a history of mucus discharge, several times all over it, then of course you ask the patient whether the patient has significant so extraintestinal manifestations you can ask a few, but you know that not every inflammatory bowel irritation will have that. Only one third of the patients will actually have extraintestinal manifestations. It's worth mentioning that because if they don't have it. But that is not the way of saying that the patient is not having inflammatory bowel disease. Not by not having extraintestinal. It's not the way. Right? You can definitely mention that. What happens in Crohn's and what happens in ulcerative colitis? What's the principal difference between the two diseases? Clinically, presentation wise? Ulcerative colitis is? Okay, blood and mucus diarrhea. Okay. Blood and mucus diarrhea. Ulcerative. What about Crohn's? How do Crohn's patients? Why right there? Yeah. Okay. I just see the pain. Right. Okay. Why do they get pain? Yes? Oh. That's not the pathology. Anybody? Guys, let me see. Can you listen to that? Okay. Does everyone answer that? Yeah. What's the principal difference in the presentation of Crohn's and ulcerative colitis? Anybody? Nobody has any idea how ulcerative colitis and Crohn's patients present. No idea. Huh? Yes? Not here. Sir told you. that they specifically talk loud. I can't hear you. I can't hear. Yeah. All right. Okay. So there's a condition called perianal Crohn's disease. But that's about 25% of Crohn's patients. Not everybody will have that. Right. Okay. That's one way. So they have fistula and all that. As a matter of fact, actually there is a set of Crohn's patients who will present to you. Before we diagnose Crohn's, the presentation is fistula. Right? So that's a set of Crohn's who present like that. They don't have the others, cecum Crohn's, they have the perianal condition. That Crohn's. Okay. So that's one way of presenting. Fistula and that kind of presentation. Anything else? You need to know this. This is a very important thing. Crohn's, the presentation, ulcerative colitis, the presentation, they are worlds apart. Their presentations. If I say that, at least can you come up with it? Presentation. Anybody? No idea.
Ulcerative colitis, they present like having blood and mucus diarrhea
Yes.
for some time, and then that's the period of asymptomatic.
Okay.
And again,
So on presentation, how do they present? Blood and mucus diarrhea. That's what it's an acute presentation. It's a very scary presentation. You get blood and mucus passing. One day you're fine. Next day all of a sudden you have blood and mucus come. It's sort of an acute presentation. Of course they have a time period where they don't have anything and then subsequently they present. But the day that they first present to you will be an acute sort of a presentation. They will have blood and mucus. That's a scary thing, isn't it? You start off with blood and mucus, that's scary. Right. In contradistinction, how do the Crohn's present? It's a chronic thing. Okay, it's a very chronic process. These are both inflammatory bowel diseases. But Crohn's is a very chronic thing. Actually, they present most of the time to your clinics with vague abdominal pains on and off. Why? They don't have blood and mucus there. They don't have that. Most of them. They present with a very distinct and vague. These are oxymorons. What do you mean by oxymorons? Totally opposite words connected together. Right? They are very vague presentations but totally distinct from ulcerative colitis. They present with vague, colicky type, intermittent abdominal pains, experience on months on end. For a long period they have been experiencing this and now they come because this is so bothersome. That's why they come. So why is that? What is that? What is that? Pain. Pain nobody can answer this question. That's the problem. It's because the bloody strictures they get strictures. Are they? That's the principal difference between Crohn's and ulcerative colitis. Crohn's patients have strictures. That's one of the principal presentations. So they present with on and off lower abdominal pain, colicky type, very weird vague pain, experience for a long period of time. Stricturing is a long-standing process. It's not a cute thing like that. So that's the principal difference between their presentations. You need to know this. I don't know how you came to the final year without knowing this principal difference between the diseases. Okay. Right. Going back to your history. Actually, you were explaining about that parental bleeding, and then you were explaining about left-sided symptoms, and then abdominal pain, and then a little bit on internet knowledge. But then I would specifically go and talk about a possibility of a rectal CA and try to exclude what? Local and metastatic spread. You did not mention anything about local spread. That was the deficiency in your history. Correct. What do you mean by local spread? Okay, so there is posterior spread, lateral spread, anterior spread, and inferior spread. Right? If it is a rectal meningitis. So if it spreads posteriorly, it involves the sacral plexus, and you get backache, pain, radiating along lower limbs, weakness sometimes, that kind of a presentation. If it spreads laterally, your ureters will be involved sometimes, and you get hydronephrosis and vague upper abdominal flank pain that get released on the pain gets relieved when the patient passes urine. Hydronephrosis pain, but I cannot settle in a minute. So you get hydronephrosis and then pass urine and then it settles up. And then, but that's something that patients will very rarely come up with. If it spreads anteriorly, more importantly, it will involve the bladder, and you get, or females, what is the structure you have anterior? Vagina. So you get, when male you get fecal urea, hematuria, and hematuria. You will not measure any of these things. And in a female, you get the vaginal discharge of fecal matter. Right? Right? So that's vital to include in your history. And then, of course, if the tumor spreads down, it needs to involve sphincters. You get fecal incontinence. That also you will not mention. These are important variables in your history that we're supposed to mention. Then, of course, your metastatic spread, that of course you mentioned. Right? When you mention about metastatic spread, now colonic malignancies, rectal malignancies, they tend to go to liver first. So you talk about the liver features. Don't tell about lung membrane before you talk about liver. Huh? So, right hypochondrial pain and yellowish discoloration of skin and sclera, and that kind of thing. Most of the time you don't get jaundice, but you get right hypochondrial discomfort because of ligaments. And then, if it is pleural, then you get lung involvement.
Pleural effusion.
That's the problem. You guys always get hemoptysis.
Pleural effusion. Pleural effusion.
Before you get hemoptysis,
Pleural effusion.
you get pleural effusions and difficulty in breathing. So you get pleural chest pains and dyspnea, exertional dyspnea, or that kind of a picture. When you get hemoptysis, only if the bronchus is involved by a metastatic deposit. That is very rare. Right? So don't say hemoptysis, that's the first thing. Every time I ask this question, answer I get every time from medical students. Now if you say about involvement of the pulmonary involvement by the hemoptysis. No, it's not. You have to be practical. That's why you learn these things. So of course then you can mention a few things about brain and movement. Right. Then once you have done that, then you can proceed to ask about family history, past medical history, surgical history, and of course your dietary history. Very important. You mentioned all that. That's good. That part of your history was actually initial part of your history you were finicky, but the subsequent part, that was great. You mentioned everything in order. That was fine. Okay. And the fact that you did not give topics before you mentioned the history, like social history, past medical history, that was good. The fact that you didn't do it was good, because now you are a final year student. You have to have some difference between you and a third year and a fourth year. So third year, fourth year, that's when you start saying, okay, past medical history, social, you start giving topics. Now you don't do that. Right? going to be a doctor in a few more months, so you have to be more professional, right? You just, because you are presenting this to another doctor, right? You are not presenting this to a lay person. So we know the history, we know the subcategories of history. You don't have to tell us what the subcategories of the history are anymore, right? Because for your benefit and your learning earlier, we told you all this. Now it's just a matter of coming out with a proper history in a nicer way. Who was in the clinic today? Did you listen to the history I presented to sir? Okay. So that's the way you should present the history. I did that because they are a lecturer and I wanted them to also see how to present a case properly, methodically and concise. You don't unnecessarily history and presentation. Right. So in your history, fine, everything is fine. I'm not finding fault with you, it's fine. You will pass. But try to organize your history in a more methodical way and you know the assignment is there. You want them collaborate with you. Collaborate on that. History and percentage collaborate with you. So, examine my case and collaborate. Then that's it. How long did I take to take the history? Probably about 15 minutes to examine and do everything. So that's what you should do, and it has to be very focused also, right? Surgery. Surgeons are very, medical factory they were known. Right? Okay. So you have to be very precise and concise in this. Your summary has to improve a little. Your examination is all right. You don't do little blunders like mentioning base of the lung in the middle of abdominal examination. That's the regulation that you do that. But otherwise, your examination is fine. Summary you will improve. Right? I told you what the best analogy for summary is. But you call a consultant in the middle of the night to mention or inform about a patient. But I don't get anything. You know, say that in negative level, the patient is also together. It's a very precise history. Okay? And in your examination also, you don't mention about, patient is not fail. If they are positive, you say that. But you principally focus on your abdominal findings. So, this is the 65 or 46-year-old female who came with a complaint of rectal bleeding for a period of 6 months. Now is not the time for you to go and characterize the rectal bleeding again, which you have done already. This is a summary, right? So you can just mention the blood is mixed with stool, and that's it. You are not going to further categorize, right? There is associated malformation of our habits, tenuousness, incomplete evacuation, and mucus discharge. Patient does not have significant features and history of intestinal obstruction. These are vital things to mention in your summary. She has no comorbidities. That's a vital important thing to mention in your summary. But now you don't say about not smoking. Right? On examination, there was nothing remarkable found on abdominal examination, and digital examination only revealed contact feeding. There is no mass fed. That's your summary. Right. Now what we do? Okay, now what will you do? You have investigation skill on your hand there. Right. Before that, you give an impression of what this patient has. I will do full blood count here. What will you do next year? What will you do? give a better answer than what she did. I'm not, it's okay. You know what I mean? Just trying to correct you, right? Give a better answer than what she said. Okay. Alright, that's a better approach than you. So you try to give an overall picture of what this patient has. Now this is how your final exam discussion goes for the long days. We listen, the examiner will listen to your history and examination and summary. You have to be more quicker in your presentation. Go for the discussion room. So most of the time, towards the latter part of your examination, when they are exhausted by listening to your histories, they will quickly go into the summary without asking anything. So have a very nice summary ready in the exam. Right? Exam में के summary डालना कि अन्य final exam में के argument में वाकी पहला argument का summary का डालना. Because the chances are that the examiner will ask you for the summary more than the history. Especially if you are a candidate going the latter part of it. Because they are exhausted listening to the same history over and over again. And this happens every year. This happens. But they have a very nice summary that impresses the examiner. Right? And then if they ask you what will you do, and you answer like that. That is a better approach. My principal point here is that whether this patient has a malignancy. So I will try to exclude the possibility of a malignancy. Therefore, that's what you would say. That's what you should say. Then what will you do? We decided to proceed with the colonoscopy in the private sector. Immediately decided to go in colonoscopy. Okay, no, that's good. Alright, okay. Only thing is, if a patient comes with peripheral bleeding and left-sided symptoms, because of the lack of resources that we have, we first initially do a flexi. Right? The patient, if you are really suspecting, now if you feel a malignancy, and you are sure that there is a malignancy, definitely you prepare the bowel completely and proceed with the colonoscopy because you are supposed to screen the entire bowel, right? But otherwise, if the patient comes with vague history like with a peripheral bleeding such as oral bleeding and without any significant mucus or venous anything, what we first do is we do a flexible sigmoidoscopy, right? And if you see something there, then of course definitely do a colonoscopy. That will be another day. The only thing is, the reason why we don't do a colonoscopy in the first go itself is because we don't have time to do that. A huge number of patients. So this particular practical point is something that we can actually mention in the exam, right? So, but the thing is, now for your exams understanding, you need to understand this fact. You will always be given a case. There is of course a definite diagnosis. You are not all to the nanny, many cases examining. All to the diagnose which a case. In that case, your answer should be a colonoscopy. Right? But let's say somebody asks you from a practical point of view, a patient comes in fresh peripheral bleeding, maybe suggested more towards a hemorrhoid. You don't go and do colonoscopy. There are indications to proceed with the colonoscopy. Right? Even with hemorrhoidal bleeding, there are a few indications why you immediately do a colonoscopy, consider doing a colonoscopy. Otherwise, got it? Clear? Okay, so colonoscopy is number one. And there was a lesion at the rectus point junction and it was biopsy. Was the cecum breached? Was the cecum breached in the cornerstone? Take a value. Is it important? Why is it important? There could be synchronous lesions. What is synchronous and what is metachronous? After how many months? After 6 months. Okay, synchronous lesion is when you can have two types of things. You can have a synchronous tumor or a synchronous lesion. What is the difference between these two? When come again, when you do the count, when you do the endoscopy, you see there's a tumor in the rectum. And then when you go to the cecum, on the way you see another polyp. It's a synchronous lesion. And then, if you go to the cecum and on the way you see another tumor, it's a synchronous tumor. So you can have synchronous lesions and synchronous malignancies. And then synchronous lesions in chance what's the percentage? Synchronous malignancies what's the percentage? What's the percentage? So there is a 5% chance of having a synchronous malignancy and a 30% chance of having a synchronous lesion. That means like a polyp or some other pathology which is not malignant. Got it? So this is the exact reason why we always do a complete colonoscopy. Let's say you did a flexible sigmoidoscopy and you saw a tumor. Then what? Will you take a biopsy? Take a biopsy, no? Right, okay. So there's no harm taking a biopsy, of course, but it's imperative that you proceed to do a colonoscopy. Right? You inform the patient, you do the colonoscopy, prepare the bowel properly and do a colonoscopy. So how do you prepare colonoscopy? Is it 4 sachets or 3 sachets? Sorry? Can you? Clearly, please. Okay. 5 p.m. The quality is only 1 p.m. 1 to 2. And into 5, we keep it. 5 to 6, we give another one. 6 to 6 to next day morning at what time? And then at 4 to until the colonoscopy. So this is for the split technique. This you need to practice that. Split the polyethylene glycol doses we split. Before and one the next day. In units where they practice 4 sachets continuous, so they give 1 from 1 to 2 and 3 to 4, 5 to 6 and 7 to 8 or something like that. And then you proceed to keep the patient fasting with an IV. Right? So different units have different policies. This is the policy that we. So in the exam we tell what the profit does. The profit, what is the defined profit. This is why myopathy and I joined. This is what I saw. So this practice is split technique of giving 2 sessions only. We give only 3 sessions, we do only 4 sessions. We give 2 on the day before and 1 the next day. Right? Okay. Do we put a clean enema? No, we don't. Right? So it has been shown that there is no point putting a clean enema after giving polyclinic guidance. So there is no space for that. Right? And then we do the bounce. So that's something we do polyclinic guidance. Okay, so now biopsy has been done. What is it? Where was the tumor?
Rectosigmoidal junction.
Rectosigmoidal junction. Now what we do? Okay, so the next priority is to stage the disease. What here? Okay, sorry, arrange one. You are not going to perform it, the radiologist will be performing it. The arrange one. Contrast enhance CT scan of the abdomen and pelvis. Did you do a chest? Yes. Right. Okay. So chest, abdomen and pelvis. Right? What are you going to do? Okay. Local infiltration and node infiltration and metastatic spread. Right. So you tell these. Come here, you were CT and I did. By doing a CT, I expect to stage the disease by looking at the metastatic as well as microscopic. Right. Anything else you would do for this patient? MRI pelvis. You do an MRI pelvis. Those who say that this patient requires an MRI pelvis, with a show of hand. Okay, 1, 2, only 4 people. So now you are doubting yourself also. You are for MRI or not for an MRI? For MRI. Yeah, so hands up those who say this patient requires an MRI. Those who say you do not need an MRI for this patient. You say you don't. You say no need of an MRI. No need. No need. Okay, so those who said no need of an MRI, tell me why you said that.
We have already done chest abdomen, CT, chest abdomen and pelvis. So that we can stage the disease. And no need of any other investigation.
Okay. Why?
Expensive. MRI is expensive.
That's the answer. That's the second explanation. So because of the fact that we don't have an MRI and because of the fact that it's expensive is the reason why you are not opting for an MRI.
Because we have already done CT.
Yeah, agree. What about the reason that you went ahead with MRI?
Golden standard. Golden standard.
Yes, to stage the disease because it's in the sigmoidal junction. Because the tumor is close in the sigmoidal junction. So we have to know whether how the spread is. So for the staging wise, the best is the MRI. For that reason.
So there are, yes, sorry. said no? Right? So that's one set of answers. This is the other set of answers. Both answers are wrong for their own reasons. Okay? Why we don't do now? The correct answer for this question is, it's ironic that you guys gave an answer like that. Both answers are wrong for the reasons that they give. Okay? The complete answer, the true answer is, this is a rectosigmoidal junction lesion, and it is above the peritoneal reflection therefore, and therefore does not require an MRI pelvis to assess local spread. That is the answer. So the answer is, this patient does not require an MRI. That's the answer. The answer, the reason for that answer is because it is above the peritoneal reflection. The rectosigmoid junction is above the peritoneal reflection. I'll tell you why we need the MRI for the lesions below the peritoneal reflection in the device. Just wait. The answer that you gave, that this patient does not require an MRI, is correct. But the explanation you gave for that is wrong. It is not because we don't have it here. It is not because it is expensive to see. It is because of that particular reason why we don't do an MRI for this patient.
We are not doing MRI for these patients, sir, because from the CT, we can at a similar level we can identify the local infection. We don't know
The thing is, the reason why we do an MRI is for rectal tumors, not rectosigmoid junction tumors. The consensus is that rectosigmoid junction tumors behave as sigmoid tumors. They don't behave as rectal tumors. For the simple reason that rectosigmoid junction is above the level of the peritoneal reflection. Why am I saying that? Peritoneal reflection? Anyone have peritoneal reflection and anything? So let's say the tumor was in the, let's say, descending colon. Does that tumor equal to the tumor of rectosigmoid junction? Yes. Because it is above the peritoneal reflection. So what happens when there is above the peritoneal reflection? The tumor is above the peritoneal reflection. No, what I mean, when the tumor is above the peritoneal reflection is, that means it is in the peritoneal cavity, it is not in the pelvis. You understand? So peritoneal cavity is huge, right? Whereas pelvic space is very compacted and small. So when there is a tumor in the rectum, it will spread very quickly to adjacent structures because it is in the pelvis. The second reason is there is no peritoneum covering the rectum, the lower part and the mid part of the rectum. Mid part of the rectum, the posterior aspect is devoid of a peritoneum, and the lower part of the rectum is completely devoid of peritoneum. So when you have a mid or lower rectal tumor, these tumors will not have the peritoneum covering. You understand? What do they have then? Mesorectum. Do you understand what mesorectum and what is mesorectum and what is mesorectal fascia and what is mesorectal fascia?
Mesorectal fascia.
Another way terms too.
Sacrum. Mesorectal fascia.
Mesorectum equals to mesorectal fat plus mesorectal fascia. So what is mesorectal fat and what is mesorectal fascia? What's the difference? Anybody? Yes. Yes. That's the answer. This is the rectum. This is the rectal mucosa. Okay, so this is mucosa. What is after mucosa? Okay. make a complete wrong opinion. So this is submucosa. Okay. So this part is thick area. I mean thick but अंदर nil parting. हरिद මේක තමයි mucosa එක. Mucosa has what? Epithelium. Epithelium. Histology in the second year.
Goblet cells.
And muscularis. Mucosa. Good. Okay. So presume that all those three are here in this thick group. And therefore, this is the submucosa. Okay, so submucosa is where you have these submucosa blood vessels and plexuses and little bit of lymphatics and things like that. Submucosa. So what you get here, what is this then? So this is muscularis propria. Alright. How then? Then what? What do you have? Then you have what? Then you have mesorectal fat. Alright? This is your mesorectal fat. It's thin in the anterior aspect and thicker in the posterior aspect. මොනවද කොම්බිනේට් නොට්ස් වලින් දාන්නේ? Mesorectal fat. What is this? Mesorectal phagia. Right. This is what the rectum has. Rectum does not have a peritoneal covering. Got it? Therefore, when there is a tumor, let's say the tumor starts here and then it starts growing in like this. The moment it goes beyond the mesorectal fascia, it comes into contact with the pelvic organ. Could be the bladder, could be the sacral fascia, sacral nerves, could be the urethra, could be the pelvic lateral pelvic walls, could be in the pelvis. Because the pelvis is such a narrow space. Because of this particular reason, rectal tumors tend to spread very quickly beyond their confinements to the adjacent structures. And therefore, if we proceed to do a surgery without knowing that, now in the surgery what can we take? When we do surgery, what can we take? We can only take this. We can't take anything beyond this. මේවට පැත්තෙන් තියෙන structures අපි ගලවන්න යන්නේ නැහැ. Because there is a very crystal clear plane between these and the structures immediately next to it. Very nice plane. This is called the mesorectal plane. It's called the mesorectal plane or holy plane or Heel's plane. These are different terms used because the person called Heel is the one who actually found this. So it's called that plane. That plane has little tissue like we call them angel's hair. It's called the holy plane with angel's hair. Immediately next to the structures plane helps us enormously. So when we go to that plane, it's like going into the wholly plane with the so that's the structure that we can take out during our surgery. That's all we can take. You understand? So if by any chance the tumor has gone beyond this mesorectal fascia, because it's such a confined space, that means we can't take the entire tumor out. That means we are leaving the tumor behind. This is why exactly we do an MRI. Because we want to find out and delineate exactly where the tumor is. A CT scan has no resolution to do that. CT scan is not capable of showing us that much of details. Because the MRI has the inherent ability to give tissue delineation, soft tissue delineation. CT can't. That is why we do an MRI for rectal lesions, but not anything above that. So rectal sigmoid junction is considered to be part of the sigmoid, not the rectal. It is not the pelvic. It's not in the pelvic, true pelvic cavity. It's above. True pelvis के लगे हैं आपे ideal में ये में is that ideal bone लेकर दिए ideal bone लेके न्यू cover करके दिए हमें round दिए नहीं round actually दिए लेकिन यहाँ पे क्या pelvic premium का बाहर नहीं. So the rectum starts beyond that point. Pelvic premium बाहर नहीं. Pelvic premium नहीं you know. We don't do it. Right. So that's the reason why we do an MRI. Understood? Right. So now you need to tell me what is T1, T2, T3 and T4. Okay. Alright. Let's forget about your case. Now it's a CT, no, we didn't do an MRI for your case. Presume that is a rectal malignancy. What is T1? Colon and rectum, there is no significant difference when it comes to TN. It's the same. Are there? But there are a few things that you need to know when it comes to T4 and T3. I'll tell you what that is. So what is T1? Okay, so it's just infiltrating the mucosa, going into the. If it has gone beyond the mucosa, what has this info? The submucosa. So it's a T1 lesion. What is T2? Muscularis propria. So this is a T1 lesion and this is a T2 lesion. You know it? So what is T3? The one that I have drawn here. The one that has gone beyond the muscularis propria into the mesorectal fat. That is called T3. This T3 is subclassified into A, B, C, D depending on the distance from this end to this end. If this length is X and if X is less than 1 millimeter, less than 1 millimeter, you can you make a muscularis propria millimeter it has gone beyond the muscularis propria for sugar into mesorectal fat, but it is involved in the mesorectal fat only less than 1 millimeter, then it is T3A. If it is 1 to 5 millimeters, this length is 1 to 5 millimeters, it is T3B. If it is 5 to 15 millimeters, it is T3C, and if it is more than 15 millimeters, it is T3D. Okay? So you need to understand why there is a concept like this. The reason for this is tumors which are lying anteriorly will, I told that the mesorectal fat layer is very thin. But the mesorectal fat layer in the posterior aspect is very thick. So මෙතනින්දම මෙතෙන්ට යන ටියුමර් එක let's say this is T3B කියලා. That is because this is only 5 millimeters beyond this point කියලා.
මේක T3B කියමු මේකත් 5 mm from this point කියලා හිතන්න. What has the more chance of involving the adjacent structure? The one that lies anterior. Got it? You understand? Simple, no? Not rocket science? Right. Okay. So this is the exact reason why the MRI, the person who reads the MRI, the radiologist, specifically mentions where the tumor lies and what T3 category it falls in. If it is anterior and T3B or something like that, but we know that it is very close to the mesorectal fascia, we know that this tumor is in very high chance of, by the time we operate, a very high chance of involving the mesorectal fascia. Again, අපි ගන්නකොට මේක ටියුබ් එකේ මේ නිච් එකේ තියෙන chance එක වැඩි. Rather than one in the posterior. Right? When you go to the lower rectum, all around the lower rectum, the mesorectal fat layer is very thin. Mid rectum එකේ තමයි මේ වගේ anteriorly පොඩ්ඩක් posteriorly හොඳට තියෙන්නේ. But when you go to the lower rectum, even posteriorly, the mesorectal fat layer is very thin. So therefore, when you go to lower rectum, so if you have a lesion like T3B, that means it is again very close to the mesorectal fascia. So the chances of this involving the mesorectal fascia by the time we operate is high. Why am I saying all this is the reason why we consider giving neoadjuvant to these patients. Because we want to shrink this tumor so that we have a bigger gap between the mesorectal fascia and the tumor by the time we go and take the tumor out. You know, that is the concept of neoadjuvant therapy. Right. If the mesorectal mesorectal fascia, if this mesorectal fascia is touched by the tumor, again it's the bacillary thing, then this is a T3, whatever, T3C or D or whatever, depending on the distance, MRF plus, mesorectal fascia plus. That means this patient definitely requires neoadjuvant therapy. If the gap between the tumor and the mesorectal fascia is less than 1 millimeter, okay, we consider that the mesorectal fascia to be almost involved. So we call it circumferential resection margin threatened or involved. Involved. We call it involved. If this gap is less than 1 millimeter, we call circumferential resection margin involved. Why do we call it circumferential resection margin? Because it's the resection margin. Surgery kalla api kapala iron karne ke circumferential resection margin. It is considered to be involved if this gap. Can you guys see it at the back? What I'm drawing here? This little gap between the tumor and the mesorectal fat. I'm not talking about the length from the muscularis propria to the tumor. Now I'm talking the other way. Talking about the tumor and the mesorectal fascia. The gap between these two. If it is less than 1 millimeter, we consider the CRM involved. If it is 1 to 2 millimeters, we consider CRM threatened. If it is more than 2 millimeter, we call it CRM uninvolved. Except this particular entity, these two patients will require neoadjuvant therapy. This is how we decide on neoadjuvant treatment. Understood? And you can only say these things by doing an MRI. There is no way on that you can comment on mesorectal fascial involvement in the CT. That is why you should do an MRI. Okay? So from here on, the doctors who are supposed to be coming out of this generation should know that MRI is an investigation for rectal tumors. I'm telling you this because we have surgeons in this country at the moment operating surgeons who still don't know that an MRI is done for rectal malignancies and the casec behind this. Alright. So at least I want you guys once you pass out to know this and the reason behind this. Alright. Right. Is it clear to you all? You don't have any doubts about this? This is the reason why we do right, okay. Then, for your case, we are not doing this because of that. Okay? So, let's say a patient who undergoes an MRI, a rectal malignant patient. That's the first investigation you will do after colonoscopy and biopsy. MRI. The real answer is it's not MRI pelvis, it's a non-contrast MRI pelvis. That's the answer. The real answer is that CJ cannot contrast enhanced MRI can non-contrast MRI pelvis. That's a term that we use. We don't give contrast because it's done without contrast. Right. Then rectal tumor you do an MRI, I told you, you do the colonoscopy, you do the biopsy and you do an MRI. Then what will you do? No depending on stage. I have done only 3 investigations. Colonoscopy, biopsy, MRI pelvis. What's the next investigation? Yes? Huh? Yes. No. No place for answers. Anybody? Colonic malignancy is sort of already. Colonoscopy, biopsy, or do the contrast index, CTR, is that dominant. Rectal or colonoscopy, biopsy, not contrast MRI pelvis. What's the fourth thing?
Contrast index, CT, and abdomen chest.
Okay. Contrast enhanced, CT scan of chest, abdomen, and pelvis. You don't leave the pelvis behind for the CT. Why? Why you don't? Now you have done an MRI, a very expensive, high resolution, amazing investigation you have already done to see the pelvis. And you are going into the shitty CT pelvis also. Why? Huh? It is because the radiologist will like to have all the cuts from top to bottom to report on a CT. That is the answer. That is why they do a CT pelvis also, although an MRI pelvis is done. Because they find it easy to report if you have all the cuts from top to bottom rather than abruptly stopping at the pelvis without showing the pelvis. They would like to know that. That's the reason. We ask this question, do you really need a pelvis? If you have already got this real nice MRI pelvis. Because MRI pelvis is done at some other place and CT pelvis is being, CT scan is done in another place. Sometimes 2 different consultants are doing these things. The consultant who does the CT would like to have all. Presume that it is the same consultant who does it, still they would like to do it. Because in one go they would like to comment everything. So that's the reason they told as to, we thought it is because they would like to see the lymph nodes. No, because you actually see the lymph nodes nicely in an MRI pelvis, the regional lymph nodes. Right? So what do you gain by a CT abdomen? Involvement of the liver. Number 2, para-aortic lymph nodes. Number 3, para-aortic lymph nodes common non-regional lymph nodes. Okay. So what is non-regional lymph nodes and regional lymph nodes when it comes to malignancy? In the colon and rectum, not colon, rectum. Yes. Yes. Sure. Anybody? Prasadi. Yes. What are the non-regional? What are the regional lymph nodes? Pararectal and iliac nodes. Out of these iliac nodes, which iliac nodes will be regional and which iliac nodes will be non-regional? Internal iliacs will be regional, external iliac, common iliac, all will be non-regional. So the reason why we do a CT is to see these non-regional lymph nodes. The external iliacs, the common iliacs, the para-aortics, these are all non-regional lymph nodes. And then that is the reason why we do a CT pelvis, CT abdomen, to see these ones. The ones which will not be seen in the MRI pelvis. MRI pelvis is a regional lymph nodes. You don't see non-regional lymph nodes there. Non-regional lymph nodes will be seen by the CT abdomen. And of course the liver. The reason why we do the CT chest is to see the pulmonary. As a matter of fact, you don't really need contrast for that CT. A non-contrast CT chest is enough, but since you are doing everything in one go, you do a contrast and CT chest abdomen. The reason why we do a pelvis is because the radiologist would like to have all the views. All right. So those are your investigations. And then of course, CPA. You have to do a CPA on colonic as well as retinal manifestations. You have to have the baseline because if the CPA is very high, we know that it's very likely to have the metastasis. It does not necessarily mean that CPA normal means that patient does not have metastasis. The sensitivity of CPA is such that the presence of it increases possibly significantly. Chances are that it will happen. What is sensitivity and what is specificity? What is possibly predicted and what is Nobody is coming up with an answer.
It shows the negative values. Sensitivity shows how much the test is positive value.
Test is doing positive. Test is becoming positive. What is positive predictive?
How much the test equals to
Yes.
Positive material is, the test is positive, actually the patient is having the disease.
Yes.
Positive
Negative
material
predictive
is, when the test is negative, actually the patient is not having the disease.
Okay. I'll tell you an easy way to remember this and work it out in a nicer way. And really understand what is the principle behind sensitivity and specificity. And positive predictive value is negative predictive. So in sensitivity and specificity, we take patients, people. Positive predictive value and negative predictive value, we take reports. Right? We take people and we take reports. First we take people. Sensitivity means you take 100 people. You take 100 patients with a disease. People can patients. You take 100 patients with a disease, and you do a test on them. May 100 patients lage test එක positive වෙනවා නම් 90ක sensitivity of that test is 90. You take 100 patients and do a test on them, and if that test is positive in only 90, that test is 90% sensitive. Specificity means you take 100 normal people and you do the test on them. And if that 100 normal people, if that test becomes negative in 95, that test specificity is 95. You know? That is the principle behind sensitivity and specificity. You take patients and do the test. You take normal people and do the test. And the test becomes positive in patients is a sensitivity. Test becomes negative in normal people is specificity. Okay, positive predictive value and negative predictive value. You take reports. You take 100 positive reports and ask all the people who underwent that 100 positive reports. That means there should be 100 people coming with these 100 positive reports. And you really do another test to find out whether this patient really has the disease. And අපි හිතමු මේ ඉන්න 100න් disease එක ඇත්තටම තියෙන්නේ 85ක කියලා. Then the positive predictive value by that initial report is 85%. Then negative predictive value means you take normal 100 reports and you call all the people who underwent that report. And you really find out whether those people have a disease through another test. And if out of those 100 people, if 15 people actually have the disease and 85 people actually don't have the disease, the negative predictive value of that test is 85%. That's the concept behind the negative predictive value. So you take tests, positive tests, and see whether they are positive in those test කරපු මිනිස්සුන්ගේ ඇත්තම disease එක තියෙනවා. And you take negative test and see a negative test තියෙන කට්ටියගේ ඇත්තම disease එක නැද්ද. හරි. So you need to know this thing if you are reading an article, because these articles always come with these values. The sensitivity can be the specificity can be that's positive predictive value, negative predictive. These are the terms they use. So if you know the real reason behind it, then you will like remember. So the test that I was telling is something like that. Even if it becomes positive, even if it becomes negative, that does not mean the patient is not having the metastasis. But if it becomes positive, there is a very high chance that the patient has. Going back to the investigation. So now we have done MRI, so colonoscopy, biopsy, MRI, CT, CT. Okay. Now what do we do? There's a malignancy. Let's presume that this malignancy is in the operation we only did a CT, so the patient has a tumor degradation. Patient is arranged for surgery. Okay. Before that, tell that you are now you have diagnosed the condition in this patient. So I would like to discuss this with the patient and inform the patient that patient this is what he has,
and if he is willing for surgery, I will then proceed to assess the fitness for surgery. Patient fitness assessment. You always take a minute to explain what is happening to the patient and get his consent to proceed. This is not the consent for surgery. This is just to proceed to do the rest. Right? Then anything else you are missing at this point? Yes. What is that? MDT. MDT is given. MDT. So you always discuss. Now make a habit. If it is a malignancy, we all have seen all of us discusses every single patient in MDT. Be it a malignancy or not, he would discuss. So always tell that you will be discussing this case in the MDT. But know what to be discussed also. MDT is not the punishment. Right? You say MDT and you are going to tell this is what I will be discussing in the MDT. Right? So I would like to discuss this case in the MDT and arrange an MDT to discuss this patient's condition, the clinical condition, and to see the resectability and the operability of this patient. That's what you are looking for. Right? You want to see whether the tumor is resectable and the patient is fit for operation. This is called resectability and operability of a tumor. That is what you will do in an MDT, right? And then you proceed to assess the fitness of this patient. For that, now we have dedicated clinics for these things. Right? So therefore, you can tell either way. You can tell that you will be arranging everything. Of course, you will be still arranging everything, but you will most likely be referring this patient to the pre-assessment clinic. Right? And a pre-assessment clinic is one patient. House of the clinic is investigations patient forms filter medical investigations report. Therefore, still you have to do the investigations. Back in our day, we didn't have PACs. All the patients will come to the ward. So once the patient comes to the ward, we will send all the investigations and get the anesthetist to see the patient while in the ward. Now things have changed. Shifts, paradigm shifts. Then we have PACs. PAC again a pre-assessment clinic. All the patients who come to the clinic will go through a PAC. So in the clinic, the medical officer will write all the investigations and tell the patient to go and give the blood to the lab and collect the reports, go and see the doctor at the PAC. PAC is called anesthetist. Anesthetist will go to the patient and provide the management whether she is happy to give anesthesia or whether she requires further assessment of this patient in terms of other investigations. Right? So you will do the basic. What are the basic investigations that you are doing? Put that down. Electrolytes, creatinines, INRs, and of course ECG and a chest X-ray. If the patient has comorbidities like diabetes, hypertension, or ischemic heart disease, of course, doesn't need to have ischemic heart disease. Even if the patient has diabetes and hypertension, means that patient is an ASA2 patient, not ASA1. So ASA2 patients or beyond, you will arrange for a QT echo, try to the cardiologist, arrange QT echo. And if you think that the patient has significant lung pathology or like a COPD, then you will arrange lung function test. Right? Now, only exam exam this is something to talk in the exam. It is not stop. Hypothetically speaking, if you think the patient has a lung problem, then I should proceed. But always remember, you try to tell what your patient has. If your patient does not have a history of COPD, don't tell about lung functions. Right? That's irritating because we don't do lung functions now. We will do lung functions only for necessary things. So always coordinate your patient. Right. Okay. So you do the PAC. And then
patient comes to the ward. Pack is done, everything is ready, patient comes to the ward. You are the house of in the ward. What are you going to do now? Okay, now you have decided, first of all, I will discuss with my consultant and to give a date for surgery. Fix a date. That is surgery ready. Surgery fixed. That's why the patient comes. Right. Once the patient comes to the ward with a fixed date for surgery, then I will now then consent. So I will first take a consent. Now you did not say that. Before you discuss everything with the patient, you say my next priority is to obtain the consent from these patients. For that I will explain the surgical procedure, explain the alternatives, and explain the possible complications. There are three things that we discuss in a consent: procedure, alternatives, and complications. Right? ये दिखा था मैं क्या? ओनम कंसेंट का आप कथा करना है वो exam में क्या consent के लिए ना तो you can get them if you say this. So then they are really want to know, then they will ask you, okay, what will you tell specifically for this patient? If they will definitely ask, what will you say specifically for this patient if you take the test? Good. Okay. Then I will tell that anterior dissection is a procedure where they can do either laparoscopically or open. So I will briefly explain how these two surgeries are done. We don't do that. Examiners are very reasonable. They don't ask how do you do the port. Right? If you say this, I have two ways of doing this surgery. Those are the alternatives. This is why I said you explain the procedure and alternatives. So alternatives are, if you are going ahead with open, your alternative is laparoscopy. If you are going with laparoscopy, your alternative is open. Like that. So you say, I will explain the surgical procedure. Depending on my consultant's preference, whether it is an open or a laparoscopic procedure, I will share the procedure information. And then, the complications. Okay. Okay. Is that it? As for the clinical, there is a small percentage of patients who may have obviously anastomotic leak is a devastating complication. You can have it, but the percentage of having that is very less. You don't say it as a first thing. That will scare the patient away. Tell about the possible complications like surgical site infections, which you will see like right, left, and center. And so you tell that. Risk of bleeding. Then anastomotic. Okay. So you tell about these complications. Right, good. So when you tell these complications, then examining the but in real life, when you become a house officer, you tell it in a nicer way to the patient. Yeah, it's a anastomotic. So can you help? Get a therapy. The operation is something that you have to do. And even may body percentages. පුද්ගල ලෝක කියන්නේ නැහැ. කියන විදිහ. You need to learn these things. House officers are consent ගන්නකොට පොත බලන්න ඉන්න කොහොමද ගන්න කියලා. Right? Very important to learn these things. This is what you are doing at the interview. Learn everything what doctors do and learn from them what was because of the idea can learn how you are in there. So you take the consent and you proceed to. If you take consent for a song, it's alright to take consent for a trauma, but here that this patient, rectosigmoid, colonic surgery, generally we don't take full stop. Where will you do full stop? For an internal lower rectal tumor, where the tumor is below the below the peritoneal reflection. Why? Yeah, because there is a possibility that anastomotic leakage is very high. General anastomotic leakage rate is about 2.5% to 5%. But when it comes to these lower rectal tumors, it increases in 4 times. The chances of anastomotic leak increases in 4 times. It even like exponentially increases if the patient has been given neoadjuvant chemoradiotherapy, specifically radiotherapy, because radiotherapy will cause poor wound healing. So the chances are that patient will have anastomotic leak. So therefore, all the patients who undergo neoadjuvant radiotherapy, you know that they undergo neoadjuvant radiotherapy for rectal cancer. Maybe mostly will be putting a stoma. What is the stoma that we put? Permanent colostomy. Defunctioning colostomy. Ileostomy. Come on. Defunctioning loop ileostomy. That's what we put. Because we want to defunction the anastomosis and preserve it. Remember, by doing a stoma, it will not reduce anastomotic leak. Anastomotic leak rate is not reduced by placing a stoma. All what it does is reduce the morbidity associated with an anastomotic leak. Understood? Simple, no? Very good. I'll give the note and thank you. Colectomies, we never put stomas. We never put stomas for colectomies. Because we don't give neoadjuvant. So that's the topic I discussed that day. That's a different presentation. That's an acute presentation. I told you in acute presentation what we do. Different tumors have different approaches, and I gave you all the possible options. For the right colon tumor we make transverse colon we make left colon we make I told you. Left colon has 3 options. So this is a different scenario. The patient is found to have the lesion without any obstruction. Electively we are proceeding with surgery. So your patient does not fall into this category. Protein target presentation acute presentation. We create stomas. We do Hartmann's procedures. If the tumor is in the left side, we do Hartmann's procedures. We put stensing and later go on. All those things matter. They come into that, not here. They are not in it, right? That is it. And solid. Still we have not opted, the entire country has not opted the ERAS protocols. What is ERAS? Enhanced recovery after surgery. So not every surgeon is adhering to ERAS protocols, where we don't do bowel preparation preceding surgery. So this is a very sensitive area where you will have to be a little witty to answer that question. So you say that depending on the consultant's preference, some consultants prefer to prepare the bowel prior to surgery for activation. In our unit, we adhere to ERAS protocols, and as part of ERAS protocols, we do not do mechanical bowel preparation. All what we do is give clean enema. When we give it just find out about 3 hours before surgery, we give a clean enema, and we keep the patient on a live liquid diet the previous day, and we give carbohydrate loading 24 hours and 3 hours before surgery, 400 kilocalories and 200 kilocalories. You are in this unit, you need to find out these things. No point. Now, not everybody has the privilege of knowing what ERAS is and what the ERAS protocol is. You guys have that privilege in the entire country of medical students, of all the 6 or 7 or 8 medical faculties. In this unit, did you know that? Only this unit adheres to ERAS. In the entire country, we have the ERAS protocol. Only Dr Malaka does that. And it's a proven and well-established system, and nobody still adheres to it. And it's sad that nobody still adheres to it, but people will slowly come up with that. So while you are in this unit, you learn what the ERAS protocol is and what we do, how we prepare. Right? It's very important. So you did carbohydrate loading doses of 400 kilocalories 24 hours before, 4 hours or 3 hours before, you need 200 kilocalories. We do it by giving a preparation for preload. We don't have preload sometimes, so we need coconut water and use all glucose, 100 grams and 50 grams. 100 grams 24 hours before, and 3 hours before. Ask the HOs how they do it. Right? Did you know this? You did. Right. So they do that. Find out that, and then we keep the patient fasting for 6 hours and give a clean enema. And once the patient is taken to the theater, we do a rectal washout. That's our bowel preparation. Right? When you bowel surgery, when you do the surgery, we still sticks to the previous protocol of mechanical bowel preparation. Even in the same unit, we have discrepancies in the management. More than I can say. Right. So remember these. How to answer very carefully in the exam. Right? Because still some surgeons do not stick to ERAS, so they do mechanical bowel. So you always tell them, this is what you learn. Nobody is going to find fault with you. You just tell what you learn, as long as what you learn is correct. Mechanical bowel preparation, having, and then of course you will preserve that. Don't ever forget that. And get the patient to have a bath the day before the surgery. It's very important. And of course, shaving the surgical site. So that the patient is the patient is there. So if you are a good candidate, they will explain currently. If you answer, they will take you from the start to this point. They will take the patient to the end. You might discuss a few things once the patient comes back. The post-operative management, pain management, fluid management, when you start feeding. Then discuss a little. Right? So this is our long case discussion with you. Any questions? Yes. That's another important thing. Depending on the patient's ASA grade. If the patient is ASA 1, of course, you don't have to reserve an ICU bed. But if the patient has comorbidities, depending on the fact findings and having strictly anesthetic instructions, then reserve an ICU bed. It's worth mentioning that as well. Okay? Any questions? Tenesmus and incomplete evacuation are two different symptoms. Incomplete evacuation, by its own terms, is self-explanatory. Tenesmus is the painful desire to defecate which does not result in adequate or satisfactory bowel movement. That is tenesmus. It's the synonym or the counterpart for strangling. Strangle is the painful desire to urinate, which does not result in satisfactory mituration. It is because of a VUGS stone or a bladder stone. I told you one day how a VUGS stone causes syndrome. So it's the same here. Right? Incomplete evacuation is because the tumor is in the rectum. And rectum is a capacity structure where when you have feces filled in, you feel like going to the bathroom. It gives you the sensation. If there is a tumor there, you get the same feeling of going to the bathroom. So you go to the bathroom and you pass a little bit of feces that is there in the rectum, and you come out and you feel you want to go back to the bathroom because the tumor is there. Right? But the tenesmus is not there. Tenesmus is you have a painful desire to eat. The reason you get tenesmus is because of now the tumor is causing you pain. Incomplete evacuation does not cause you pain. It's just a feeling. Tenesmus is pain. Your pain, your nerve fibers are involved by the tumor. It's a painful thing. When the tumor is just adjacent to the nerve fibers and when the feces get stuck on top of the tumor, you have the desire. But now it is associated with pain because now the tumor is causing pain. But you pass feces, but you pass only a little bit of feces. You don't pass adequate amount of feces because the rectum was not entirely filled with feces. It was also partly occupied by the tumor. So you only pass a little bit of feces. So that is tenesmus. Understood? Okay. Can I keep going then? Any questions? Which one?
So we just found BMC was regarding to today's topic.
Okay. Then you go ahead. That's the question. 50-year-old. 50-year-old male with history of colonic adenocarcinoma, reason also. Ultrasound of abdomen reveals suspicious lesion in the liver. In this patient, normal CT levels rule out the possibility of secondary. And we can put the answer to that. True, false, done, and single best responsibility. True, false. Normal CT levels rule out the possibility of secondaries. That's false. CT abdomen is needed to assess the operability. Operability? Resectability. Peritoneal deposits are better seen in CT. Deposits better seen in CT than laparoscopy. That's true. Laparoscopy is seen
That is why you do a laparoscopy. Diagnostic laparoscopy is done to see peritoneal lesions, which are not seen in CTs. PPCT is something that is a PET-CT. PET-CT is a tool to look for extrahepatic vents. True. Removal of the hepatic vents improves the disease-free survival. Yes, that's why there is a place for colorectal tumors. There is a place for liver resection in colorectal. Metaconazole synchronous liver issues. So the question CT abdomen needed to assess the operability. I'm not very sure whether they were considering resectability or operability. Definitely for resectability, you need a CT abdomen. Operability is not a term that we designed by CT. Check operability by the patient's fitness for surgery. Operability is a different, but unfortunately, not many people know the difference between these two. I'm sure the examiners know that. So if you are not sure, just leave it rather than getting a negative mark on it. Mama නම් සමාන වෙලාට ඉවන්තෝ අපි තරම් ඉන්නට අනිත් පැත්තේ දන්නාද කියලා මාව සැකයක් තියෙනවා ඉතින් it actually happens. Now see, if they are putting for operability without actually considering this operability and resectability, they do not want to check whether you know the difference between these two terms. Just the fact that they want to know whether you know that this is investigation before the patient undergoes surgery. In a coroner, I don't know whether that is what they were checking. Because that question is not, I don't think that that statement was made to find out whether you know the difference between resectability and operability. I don't think they expect that from you. So because that CT abdomen is probably considered process. 45-year-old male diagnosed with rectal CA, most appropriate investigation to assess the local spread of tumor. Rectal CA. This is true or false in the principle. Best of 5 and this week's my best of this. True or false regarding colorectal cancer. Around 40% rectum is affected. I know spinning fracture is about 5%, 4 to 5%. Colonic is about 38. So 40 is probably correct. Minute figures what about billion colonoscopy is an alternative investigation to various minima. Colonoscopy is an alternative investigation to various minima and pretty sure this question has to be stopped. Colonoscopy is not an alternative to various minima. The statement should be various minima is an alternative to colonoscopy. Colonoscopy का करने very one तो मैं भी various minima का दान. But now various minima is not in the guidelines. It's out. What's the alternative to colonoscopy? Colonoscopy का करने very one. CT colon. That's another thing I should have asked for. So by no means the class that I took today is complete. Right? There are a few things that I might have left behind not talking to you. Right? Such is that CT colon. I forgot. Right? If you can't do a colonoscopy, you do a CT colonoscopy. What's the disadvantage of CT colonoscopy over a colonoscopy? You can't take a biopsy. Simple as that. What's the advantage? What's the other problem with CT colonoscopy? You have to still prepare about it. CT colonoscopy, you have to prepare about it. What's the advantage over colonoscopy?
Low risk of
The
perforation.
operation risk is not there. Almost not there. Then, other than the colon, you can see other
other pathologies because CT cologram you can do it, and plus you can do the rest of the CT abdomen. CT cologram you give gas CT colon dilate then you do the CT. Number CT colon that's a CT cologram. But you are doing a CT, no? So the CT means it's a computed tomography. You will be taking spiral slices of your entire body anyway. So those are stored in the computer anyway. So you can retrieve them and generate other beams, coronal beam, your sagittal beam, axial cuts, all that you can take. So not just the colon you will be looking at, you will be looking at the liver, you can, so at the same time, so when you do a CT cologram, it's the chance for you to do the chest abdomen pelvis at the same time. Right? 20% of leakage is accepted in anterior resection. No, that is so wrong. Leakage 20% so 2.5 into 4 times. Maybe 10. Risk is high by low fiber. Colorectal carcinoma risk is high by low fiber. Actually, red meat, right? Red meat is low fiber. Yeah, I presume they should translate as true now. Low fiber diet.
You wanna die now?
නෑ මම කොරෙක්ටර් පිටින් අත්තම කරන්න හිටියේ
You wanna die
දැන්
now, bro? You wanna die now, bro?
So how about transrectal so how about transrectal endoscopy?
Risk factors for colonic cancer.
Endoscopy ultrasound scan එක කරන්න පුළුවන්.
20% of cases are associated with familial clustering. So that means you have familial diseases, colorectal syndrome, HPCC, and other risk factors: inflammatory bowel disease, smoking, consumption of red and processed meat, alcohol, diabetes treated with insulin, low physical activity, metabolic syndrome, obesity, or high BMI. Those are the other risk factors. There are protective factors. Adhering to 5 healthy lifestyle factors can reduce colorectal cancer. What are those 5 healthy lifestyle factors? Health, weight, physical activity, non-smoking, limited alcohol consumption, and healthy diet. Right? You have those 5, it will reduce, it will protect you. Fish and legumes are protective. Aspirin and NSAIDs are protective. Diabetes treated with metformin is protective. Well-known thing now. Diabetes treated with metformin is protective here. Cancers, not just colorectal, it's protective for prostatic cancer also. Risk factors that are associated with poor prognosis. Risk factors given etc. Even poor prognosis. Smoking, metabolic syndrome, obesity, diabetes, and red and processed meat consumption. Better prognosis is seen with post-diagnosis fish consumption. Family history is protective, it seems. If you have family history, right? You early diagnose, you can diagnose it. So the moment you have colorectal bleeding and you have family history, the patient will come to an doctor. So that's a protective. So those are the risk factors, those are the duties. So low fiber diet per se they don't mention anything about it. I බලන්න මේලියන් ලබ් එක කියවලා අලුත් මේලියන් ලබ් එකේ Generally these questions are from million lab for you all. common of the infections.